Hello? This is the ARD study note. This note is part 3 of Supplemental Oxygen Therapy, and the contents cover the high-flow nasal cannula, a high-flow system device, reservoir system devices, and the selection of delivery devices. As explained in part 2, the Venturi mask and air entrainment nebulizer, which use the Bernoulli principle and constant jet mixing, have a decrease in total gas flow as FiO2 increases. At a certain point, the total gas flow drops to less than 40 liters per minute, losing its function as a high-flow system. This limitation has been resolved with the emergence of the high-flow nasal cannula, namely HFNC, whose use is rapidly increasing nowadays. In addition to this, the HFNC is a device with several clinically useful advantages. Various models, including the earliest model Optiflow, as well as Airvo 2, Vapotherm, Omnix, Massimo, etc., are being used in clinical fields. While each has slightly different structures and functions, the basic mechanism and structure are based on the initial model, Optiflow. We will examine its function through this model. The HFNC consists of 4 main components: air-oxygen blender, active heated humidifier, single heated circuit, and nasal cannula. The air-oxygen blender plays a pivotal role. This device allows for independent adjustments of the FiO2 and the total gas flow. FiO2 levels can be set between 21% and 100%, while the total gas flow can be adjusted from 10 to 60 liters per minute. Unlike the Venturi mask and air entrainment nebulizer, where an increase in FiO2 leads to reduced total gas flow, the high-flow system retains its full functionality. Due to this feature, it provides a much higher and more predictable gas flow and FiO2. This matches the patient's inspiratory flow rate, and by supplying high flow to the upper airway, the anatomical dead space is reduced, and the washout of carbon dioxide is promoted. Additionally, due to the high flow, a positive end expiratory pressure, or PEEP, is formed. One study reported that, when breathing with the mouth open, a PEEP of 0.7 to 2.7 centimeters H2O is formed, and when breathing with the mouth closed, a PEEP of 1.7 to 7.4 centimeters H2O is formed. However, it's unclear how clinically effective this level of pressure is. Moreover, while one might want to enhance the PEEP effect by applying a high flow from the HFNC, it's not practically feasible to instruct patients to breathe with their mouths closed. Using the active heated humidifier and single heated circuit, patients are provided with warmed and humidified air, improving their comfort. Additionally, the water content in mucus rises, aiding in the removal of secretions and preventing desiccation and epithelial damage. As a result, the metabolic cost associated with breathing diminishes, leading to a reduction in the overall work of breathing. The generally recommended temperature to increase the water contents of mucus and facilitate its removal is 37 degrees Celsius. However, at this temperature, patients might feel discomfort due to the warm air. According to a study examining the temperature of HFNC and patient comfort, it has been reported that patient comfort is significantly higher at around 31 degrees Celsius compared to 37 degrees Celsius. Therefore, for patients without excessive sputum, considering a lower temperature setting may be beneficial. And, due to the use of small, loose-fitting nasal prongs, patients may feel more comfortable than when using masks. Owing to these advantages, it has been applied in clinical situations like ARDS, pneumonia, idiopathic pulmonary fibrosis leading to hypoxemic respiratory failure, cardiogenic pulmonary edema, postoperative status, post-extubation, and procedures like endoscopy or bronchoscopy. There have been related reports regarding these applications. However, despite many clinical studies, there isn't enough evidence yet to draw a clear conclusion or provide a definitive recommendation. In 2022, the European Respiratory Society released a clinical practice guideline on the application of HFNC in acute respiratory failure. However, due to the uncertainty of the related evidence and variations in available resources, all the recommendations remained at a weak or conditional level. Nonetheless, since it holds a clinically significant position, it is necessary to be aware of the 8 key questions, PICUS, and the related recommendations from the guideline. Firstly, in cases of acute hypoxemic respiratory failure, where there's no rise in carbon dioxide levels and PaO2 drops below 60 millimeters of mercury within 7 days, the decision between applying HFNC or conventional oxygen therapy was given a conditional recommendation in favor of HFNC, based on moderate certainty of evidence. Secondly, in patients with acute hypoxemic respiratory failure, when deciding whether to use HFNC or non-invasive ventilation, HFNC was given a conditional recommendation. However, the certainty of the evidence was very low. Thirdly, there are times when non-invasive ventilation needs to be temporarily stopped, whether for feeding, speaking, due to mask pressure, or to test the possibility of weaning. In such cases, it's conditionally recommended to use HFNC over conventional oxygen therapy, based on a low certainty of evidence. Fourthly, for post-operative patients with a low risk of respiratory complications, it's recommended that either conventional oxygen therapy or HFNC can be applied. Fifthly, for post-operative patients with a high risk of respiratory complications, the application of either HFNC or non-invasive ventilation is recommended as being equivalent. Sixthly, after extubation of non-surgical patients, it's conditionally recommended to use HFNC over conventional oxygen therapy, based on a low certainty of evidence. Seventhly, for non-surgical patients with a high risk of extubation failure, and no absolute or relative contraindications to non-invasive ventilation, it's conditionally recommended to favor the use of non-invasive ventilation over HFNC after extubation. Lastly, for patients with acute hypercapnic respiratory failure, characterized by a pH decrease to 7.35 or below and a PaCO2 exceeding 45 millimeters of mercury within 7 days, it's conditionally recommended to try non-invasive ventilation before considering HFNC, based on a low certainty of evidence. This recommendation emphasizes the fundamental limitation of HFNC as a supplemental oxygen supply device, not a ventilator. It underscores that HFNC has an absolute limitation when it comes to CO2 elimination, meaning it cannot replace non-invasive ventilation. Thus, to summarize the clinical positioning of HFNC, before the advent of HFNC, the approach for hypoxemic respiratory failure was to first try conventional oxygen therapy. If there was no improvement, the next step would be non-invasive ventilation, and if deterioration continued, mechanical ventilation would be applied sequentially. Once improvement was seen, these steps would be downgraded in reverse order. It's evident that there was a significant clinical gap in appropriately covering the patient's needs during this process. However, with the emergence of HFNC, this clinical gap can be significantly bridged. One important point to consider when using HFNC is its application in patients with transmittable infectious respiratory diseases, such as tuberculosis, influenza, and COVID-19. Due to the high flow, pathogens present in the upper airway, like tuberculosis or viruses, can be aerosolized into the air, posing a risk of transmission to others. Therefore, it's imperative to use HFNC in an isolated environment, and healthcare professionals must employ appropriate respiratory protection. The next topic is the reservoir system device. The reservoir system is designed to store the oxygen supplied during expiration in a reservoir bag or similar container. When a patient's inspiratory flow exceeds the provided oxygen flow, the stored oxygen is delivered alongside the supplied oxygen, ensuring an adequate amount of oxygen is delivered. Devices included in this system are the reservoir cannula, partial rebreathing mask, and non-rebreathing mask. The partial rebreathing mask allows a portion of the patient's exhaled CO2 to enter and remain in the reservoir bag during expiration. During inhalation, the patient might rebreathe this stored CO2 along with the supplied oxygen. This poses a risk for the patient as they might continuously rebreathe a part of their own exhaled CO2. On the other hand, the non-rebreathing mask is equipped with valves both between the mask and the reservoir bag, and at the expiratory port. This design ensures that the exhaled CO2 doesn't enter the reservoir bag during expiration. As a result, only pure oxygen remains in the reservoir bag. During inhalation, the patient breathes in this oxygen and room air, eliminating the risk of rebreathing their own exhaled CO2. A variety of devices can be utilized for supplemental oxygen therapy. Choosing the appropriate device based on clinical situations can significantly influence patient outcomes. To select the right device, one must consider three main factors: the purpose of the supplemental oxygen therapy, patient-specific factors, and the performance of the device. The purposes of supplemental oxygen therapy are to increase the FiO2 sufficiently to correct arterial hypoxemia, reduce hypoxic symptoms, and minimize the workload on the cardiopulmonary system. Patient factors to consider include the severity and cause of hypoxemia, age group, degree of consciousness and alertness, presence or absence of a tracheal airway, stability of minute ventilation, and whether the patient is a mouth or nose breather. Furthermore, when choosing a device, it's vital to consider the actual FiO2 it can deliver and stability of FiO2 in response to changes in the patient's respiratory demand. In conclusion, when administering supplemental oxygen therapy, it's imperative to make right clinical decision, right device selection, and right set it up to achieve maximum therapeutic effect. This was part 3 of our supplemental oxygen therapy, which covered high-flow system devices including high-flow nasal cannula, reservoir system devices, and the selection of delivery devices. Thank you for listening.